This conference will now be recorded.
Okay, since we're recording, you can call me Marlon Perkins.
Okay, great. Did you bring your animals with you? We can't see
I
them.
brought Jim.
Okay. So AnCan is grateful to the following sponsors for making the recordings possible: Bayer, Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. We respectfully note that AnCan does not accept sponsored promotion. No, any drugs, protocols, or devices recommended in the discussions are based solely on anecdotal peer experience or clinical evidence. AnCan cannot and does not provide medical advice. We encourage you to discuss anything you hear here in these sessions with your own medical team. So we will get started. We have two new people today. Let's see. You are first on the list. If you'd like to tell us a bit about your story, that would be helpful.
Oh, main on.
Yes, go ahead.
Hi, Dr. Mark. Yes, I know Rick had mentioned to you about my case before about, the linear accelerator, but now I just had, so I've, just some background information. Uh, I was classified as intermediate, high risk, unfavorable. But then again, since I'm also a T3B, I've automatically considered high risk. Um, and speaking of the risk uh, speaking of the risk class, I was curious if there's any information or resource regarding the MSK nomogram classification, because the radiation oncologist I'm going to see did his fellowship from Memorial Sloan Kettering. So, in addition to the NCCN guidelines, he also gave me some percentages based on the MSK. So, is there any online resource I could look that up regarding where I fall in between the MSK and the NCCN guidelines?
I don't think they're ones that contribute and will differentiate or compare one system to another. I think one of the problems that we have, and one of the things that is most confusing, is that we have multiple tools to evaluate our disease. We have the pathology, we have genomics, we have genetics, we have the volume of the largest lesion, we have the MRI appearance, and now we have PET scans. One of the problems with using these prognostic tools is that most of the data that goes into forming these tools and guidelines were pretty much put together before the PET scanning was introduced. So, is this the link, John, to the nomogram that you posted?
Yep.
Okay, if you go to the top in the upper right-hand corner of the screen, for everybody but Tom, there's this little box there next to the person and between the person and the gear. You click on that, you can see comments in the chat window, and we have the link to the MSK nomogram. It's a very helpful tool, but again, these are all tools, and you really want to get that interpreted because again, any nomogram is great, but it doesn't necessarily mean that the data and the outcomes that you might expect at MSK will be the same as you go to your community hospital and get treated there. So I think these should be looked at as guidelines and not facts. And they're a good starting point for discussion with your oncologist. But I don't know how helpful. I'd be cautious about using nomograms at this stage when we have a whole lot more information um, in the armamentarium than when the nomograms were first developed. Does anybody else have any comments about that?
Well, for example, Tuke has had a PSMA test, which wasn't even invented probably when the nomogram got rolling.
Okay, so that nomogram is really kind of outdated guidelines, and it's more should be rely more on the NCCN guidelines.
Well, I think, the guidelines are consensus committees, and it's interesting because we have put together a group going over those guidelines. And I think the last time, Michael, I know that you looked at one of those guidelines for the patient document. We had over 100 different comments, was it?
That's correct. Yeah, quite a bit of.
Yeah, so it's not as if you can look at one form and get, this is the only way to do it. These are, you want to know where you are in the ballpark. These are great tools. If you want to, to really make the decisions, you need to talk to the experts and develop a consensus from that, as well as what the nomograms and guidelines say. Because sometimes in guidelines, they are just that, they're guidelines. They're not definitive treatment protocols that are going to guarantee a certain result.
No,
Rick?
my doctor is actually at Kaiser, but he just happened to reference the MSK nomogram on my
Right.
on
So when I was diagnosed, the first thing that was handed to me was that MSKCC nomogram by my doc at Kaiser. And it was really, really helpful. And in the end, it actually helped me make the decision I made. Now, what I want to say to you is that the NCCN guidelines have absolutely nothing to do with the MSKCC nomogram. They're totally unrelated. You do have to put in your stage, and the stage, I believe, is defined in the NCCN guidelines. I'd have to look and see where the reference is for that. But the guidelines have got nothing at all to do with the nomogram. What the nomogram is a decision-making tool, and the guidelines are telling you how your disease can be or should be treated. Okay? I mean, before I go on, I want to make sure you sort of get that difference that we're talking about.
Yeah, I probably have to look at the actual the MCC nomogram to see. But yeah, I mean, okay. I thank you for making that distinction that they're not the same, and I should probably refer to the MSK guidelines, right?
No, but there are no MSK guidelines.
Oh, it's just the nomogram.
Okay, there are no MSK guidelines, and I'm almost certain we've provided you with these guidelines previously. I provided them to you when the first time you came into the high risk, and what this is going to tell you is how likely your disease is to recur if you have surgery. That's all it's going to tell you. How likely your disease is to recur if you have surgery. If you have the treatment that you're on, it's not going to tell you anything. Don't even waste your time, because all it's going to do is confuse you.
Oh, okay.
Okay, I mean, again, you're running down a rabbit hole you don't need to run down.
Oh, okay.
It's not, it is a fantastic, notwithstanding the caveats that Dr. Mark expressed, which are all appropriate and all correct, it is a very, very good tool for men who are 4+3, 4+4, who are trying to figure out should they do surgery or should they do radiation.
I see.
Because
Okay.
a lot of times in that situation, if you do the surgery, you may finish up having to do radiation and hormone therapy anyway,
Oh, okay.
right?
Yeah, no, I think I'm beyond that point now. So,
Right. So don't even go there, because all it's going to do is make you think, well, what about this and what about that? And you're going to wonder about, well, is this about me? And that is not a tool that you need at this junction, because you've already started your treatment and you're into the treatment. So forget now. The guidelines are a different ball game, and you can find early patient guidelines in patient language, and you can find them in the doctor's language as well. And those may help you, although guilty as charged. I still have to finish off going through the advanced part of that, which I haven't done. I'm sorry, Mike, but I will promise I will get to it. I think about it all the time. But we submitted 80 comments on the 23 version, of which they adopted about half, and we've already got about 60 or 70 comments or more on the 24 version. So it's not as good as we'd like it to be.
well,
That's it.
I think I've watched part of your Astro recap this year, so I have to. I learned a lot from that too.
Yeah, but again, the ASCO recap has got nothing to do with the guidelines. The
Okay, I mean,
ASCO
it's
recap, nothing to do with the guidelines. The guidelines, just for everybody's benefit, the guidelines, the ones we're talking about are the NCCN guidelines, although ASCO has guidelines, the AUA has guidelines, and we often are asked to review them from a patient standpoint. The guidelines are a set of instructions, largely for the doctors, as to how they should treat a situation. So they set out what is expected to treat somebody with T3B disease or T2B disease. And based on T3B, based on the Gleason score, based on a whole bunch of things. And then that's put into friendly language so the patients can understand it, so they know hopefully what the doctor's saying to them. But that's what the guidelines are. They are, if you like, what we sometimes refer to as standard of care. They set the standard of care. So if your doctor is not doing something that is called for example, and this isn't so much for this group, but it comes up all the time in the other group, if they haven't done genetic testing, germline genetic testing for you, and you're high risk, they're not meeting standard of care, because the guidelines say you've got to get germline tested. So if Kaiser, for example, says, oh, Toot, come back next year and we'll do germline testing, you say, no, I'm high risk. I'm entitled to germline testing now. And that is the standard against which we hold Kaiser when it treats its patients.
okay. Thank you very much. That's all I had to contribute.
I'm pretty confident that you're on the right road anyway, Took. I bet you that if you had a prostatectomy, your chances of recurrence would be very high. So going the radiation route, being on ADT like you are, I think you're right. You probably would be right on those guidelines, but you can check it out and make sure.
One of the things that I think is important and perhaps may be gained by looking at the MSK nomogram, there's an interesting study where they did a PET scan and found that there were lesions in lymph nodes, so that there was lymph node involvement Then they went ahead and did the radical prostatectomy, and then they came back afterwards and repeated the PET scan. And in a third of the cases where there was disease beforehand, there was still disease postoperatively on the PET scan. So the issue really isn't answered if surgery is not 100% guaranteeing that you're removing all the affected lymph nodes. Perhaps using a tool like that guideline to say what is the likelihood of involvement in the lymph nodes may point to whether whole pelvic radiation would be beneficial with the addition of the lymph nodes. One of the exciting things that's coming up is looking at fluorescent PSMA molecule that can be administered at the time of surgery so that they can actually shine a fluorescent light in and see if there are areas that light up that need to be excised intraoperatively. So there's research going on that. But if you're at a very high risk of having lymph nodes, they can treat that and cover that with the radiation, where surgery may be kind of iffy. Rick, go ahead.
No, I'm sorry, I need to take my hand down.
Oh, okay. Any other comments before we move on? Okay. Tom Wilson, let me tell you some of the stuff that I have, and then if you'll fill in the rest of the story. I have that you're 58 years young and had a PSA of 7, had biopsies that showed 3, 4 plus 3, 3, 3 plus 4, and a 3 plus 3. The 4 plus 3 had 2 cores had very high 90% and 70% 4. So that's a fairly significant finding that would put you out of the category for active surveillance. I didn't notice where that biopsy was reviewed and read, and whether you've had a second opinion on that. And I know that prostatectomy was recommended. I'm wondering about PET scan, whether you had a PET scan done and what that showed. So if you could tell us your story, that would be helpful, Tom.
Yeah, sure. Thank you. And word out to David Muslin, who introduced me to this group. So thank you. So some of that's accurate. Some of it's not. Close. I'm 57, so I'm not older than I think. I'm older than I think I am. But anyways, my biopsy read positive cancer in 7 of 12 cores. The highest percent was 4 plus 3 equals 7, with 90% Gleason 4 tumor in one of the cores. The others were 70, 30, etc. I received a PET PSMA scan that showed no cancer outside of the prostate. I've talked to Dr. Ashley Ross at Northwestern. He's the one who performed my my biopsy. I have since also gone to Dr. Brian Helfand at Northwestern. I've also talked to a person up, a Dr. Borjan up at Mayo. Recently, I also talked to Dr. Eggemeyer, I think is how I pronounce his name, Eggener at University of Chicago. So I've had 4 urologists, I guess, look at my biopsy results and weigh in. I've also talked to a radiation oncologist out at Stanford. I'm scheduled to talk to a radiation oncologist at Northwestern next week. All of the urologists suggest and recommend surgery, given my age and where it is contained inside the prostate, including even the radiation oncologist at Stanford. So that's kind of where I am. So I'm evaluating what the best options for me are. Obviously, I'm aware of the side effects of surgery and side effects of radiation. So I'm trying to obviously make the best choice for me going forward. So any information that you can glean on my situation would be very helpful, I guess.
Okay, so let me make some comments. I would apologize to those people who have heard this speech before because it's a fairly common one. One of the biases is just what you said, that you're a young man and surgery is better. You're going to hear that from many urologists. The problem with that is better than what? If you're saying at 57, would you do a better job going through surgery than someone who's 77? Absolutely. People who are 77 are going to have more surgical side effects, and it's going to be more traumatic. What they don't have is evidence to say that you are going to have a better outcome with that. What you could end up with is the possibility for the next 40 years of having incontinence and erectile dysfunction. The side effects from surgery are immediate. And there are people who can have life-threatening complications. One of the fellows in one of the other groups I'm in had a pulmonary embolus, and this guy was a young, healthy 59-year-old marathoner who died from a pulmonary embolus after surgery. Wearing a catheter is not fun. Having done that after a procedure that I did for 12 days, I wouldn't enjoy that in any case, and you don't have to do that with radiation. Now, one of the problems when you talk to a urologist is they're going to tell you there's surgery and there's radiation, and that's really not the case. There are many different radiation machines. There's brachy, high-dose brachy, low-dose brachy, and there are SBRT. SBRT can be with CyberKnife, with TrueBeam, or with MRI linear accelerators. And they all have different results. The Mirage study showed 60% fewer early side effects with an MRI guided machine because the margins are smaller. They don't specify whether they've used a protecting gel. Not everybody agrees that that's going to cut down side effects, but it may. There's also a test called PROSTOX, PROSTOX, which looks at your genetic profile to say whether you're more sensitive to the higher dose rate that's seen with SBRT. So I think the state of the art now is the MRI linear accelerator, followed by CyberKnife S7 machine. There was a recent study a few weeks ago that came out and really showed no benefit from proton. Most of the people who are doing proton are doing 45 sessions. Some at Mayo, I think, are doing 5-session SBRT, but there really is no advantage to the proton other than the time per session is going to be reduced. The MRI machines cut down the margins, so you have a 50 to 60% reduction in the exposure of normal tissue to the radiation. And it's that normal tissue that puts you at risk when radiated to future cancers. With the SBRT now, they're saying that the added risk of a secondary cancer is going to be in the 5% range. I'm sorry, 0.5% range, 0.5%.
Wait, which one? I'm sorry. Could you back up?
Yep.
I'm sorry. What did you just?
If you do, one of the things the urologists will tell you is if you do the surgery, if you do the radiation, it puts you at greater risk for a secondary cancer. And right. The problem is that a lot of the data that they garnered were with different machines. When you use a TrueBeam machine versus the MRI linear accelerator, you are radiating 60% more normal tissue with the beam because the margins are greater with those sessions. So there have been publications that say at most you're looking at about 0.5% increase, and these cancers can be curable too. I mean, the risk of a secondary cancer at 0.5% versus BCR risk that we face of approximately 30%, give or take. The concern should be the biochemical recurrence more than the secondary cancer. And it also should be side effects. I mean, for me, I would take the risk of a secondary tumor versus going ahead and not having incontinence for the next 40 years.
Right.
So they're tough decisions to make. I don't know if they talk to you about shortening of the penis. With surgery, they're cutting out a portion of the urethra that can be 1 to 2 inches in length. And if you lose 1 to 2 inches of penile length, it may be such that you're unable to pee standing and have to sit down to void. Yes, you can have issues with erectile dysfunction after radiation. If you don't have radiation, you don't have prostate cancer, you can have difficulty with this. And I've heard recently one rule of thumb is 10% increase for every 10 years. So if you're 60 years old, there's probably a 60% chance of ED without prostate cancer and going through treatment. So we have to weigh all those factors together. Jim Straight.
Yeah, I think Mark hit the nail on the head. The side effects from prostatectomy are immediate. You wake up after surgery, you've got it. If you're 57 years old, you're going to have to live with whatever that is for the rest of your life. And they frequently say that younger men have the most benefit. But speaking as somebody who had a prostatectomy at age 58, we also have the most to lose. And it isn't just erectile dysfunction, it's shortening, it's loss of sensation, it's quality of orgasm, it's leaking urine during sexual activity. You ought to go and look at Mulhall's book on saving your sex life and look at the possible effects, side effects of surgery, because it's a lot more than they tell you about. They focus solely on erections, and that's just a small part of it.
Yeah. Okay.
As a minimally invasive surgery, a surgeon, I didn't do this type of surgery, but I certainly walked by the rooms and saw it. Blood loss may be reduced, but not always. The robot doesn't make the surgery any better. You can see better, but there's no indication that robotic surgery is really going to provide for a better outcome after treatment. Govinda, I think you had a comment to make.
Yes, I just wanted to tell what happened to me. I was diagnosed with 4+3 recent prostate cancer about 8 years back when I was 72 years old. And I was in Canada, and SPRT was not an approved procedure at that time by the Canadian health authorities. So I took SPRT on a clinical trial, phase 2 clinical trial. And after 8 years now, I'm 81 now, I have no serious side effects. I am practically having a normal life. And it may be only my case, it may not be a representative case, but from my experience, I'm glad that I took that option. I was also told surgery is better at that time at 71. After that, it may be difficult. And also, I was told about the story that once you have radiation, you can't do any surgery later on. But also, you should remember that at 8 years back, it was not the latest machines with MRI live control. It was the old-fashioned. They put 5 golden seeds to locate the prostate cancer area and did that in 5 sittings. After 8 years, I still play some tennis, some golf if it's not possible, more or less the practical life. And also about the erection part, you have to compare with what you should have been at 81 now. You don't compare what you can have at 60, because the loss of that is from the place you start. What you had at 71 and what you have now, that should be the comparison. That is my take on that, and hope it will help you, and all the best. Thank you.
Thank you.
Thanks so much. One of the comments that you made, Govinda, that I think is important is that another myth is that once you have surgery, going back and doing radiation is a lot harder. And yes, it's harder. Also, doing radiation again after surgery is harder because the bladder neck is moved higher in the pelvis, and there's a bigger area, and movement in internal structures can pose a greater risk. But in any case, doing radiation after surgery or surgery after radiation, you don't have to. You can either use focal treatment, you can use radiation again. Oftentimes, if it's radiation done initially, the lesion may be at the edge or outside, and it may be seen with a PSMA PET scan, so you can direct just to the area that's involved. And you don't need to go ahead and do surgery if you did radiation first. So that's one of the myths to clear up as well. Let's see here. AnCan Rick, you have your hand up.
I do. So, and I'm taking it down right away this time, Dr. Mark. Tom, a couple of things we suggested to you back in the day. When was this? In September 24th. And I'd like to check if you've done them. Did you get a second opinion from Dr. Zhu on your on the 4+3?
I did not.
Okay. You've got to do that. It's real important. Why?
Okay.
Because if you're not a 4+3, if you're 3+4, or if you're a 4+4, it makes a huge difference in terms of your decisions, or a significant difference. So that is really, really important. Yes, you can go get second opinions till you're blue in the face, or, blew up your Khyber. But the problem is you don't know. It's hard for you to interpret the decisions because you don't have the knowledge. So you're listening to what Egner's saying, or you're listening to what Helfan's saying, but you don't have the knowledge. And we've got to be absolutely sure what your Gleason is, and we cannot rely on that local decision. So if it were me, I wouldn't do anything until I got a second opinion and a confirmation of my biopsy. It's really important. Okay. Second thing, did you? But really, this should be done after the confirmation of the biopsy. Did you run that prostate cancer nomogram we were talking about earlier?
I don't recall you recommending that, or I don't have that. No.
Okay. Well, in the email that I sent you of September 24th, there were 5 points, including suggesting you see Dr. Egner. And the fifth one was run the MSKCC prostate cancer nomogram to see what the likelihood is that surgery alone will be successful.
Okay.
So before you go in, so you can find that email from us back on, right? And you can find that email, and there's a link to the MSKCC nomograms. The problem is that that information, first of all, it's a little bit flawed, as Dr. Mark explained, because it doesn't include the most up-to-date methodologies, but it's still pretty accurate. I can tell you I relied on it back in 2007, but it was different. But it will change subject to whether you put in 3+4, 4+3, 4+4, God forbid 4+5. And until you really know what you are, I don't see how you can make a decision. Now, you can run into surgery next week, which is what you're talking about. But for me, you don't have, you're not playing with a full hand of cards. I'd like to ask Boykin, because Boykin was a comparable age when he got his surgery. And I want to know, did you get all the information you needed? Do you think Tom has all the information he needs? And what are your thoughts on getting surgery when you did, Colonel?
Okay, so I don't think he has all the information he needs. That's the easy one. I think it sounds to me that perhaps talking to too many people is not a good thing. In my case, I had a kidney that I was also concerned about. So my team was augmented with a couple other people that most people don't have because I had a kidney transplant. But I definitely think that you need to follow the advice and make sure that you're getting the right inputs because if I had to do mine all over again, I would still do the same thing, but I would be a little bit more investigative as to making sure that I understood all of the long-term consequences. Because one of the things I'm dealing with right now, so it's like the guys have mentioned, is urinary incontinence, and I didn't really expect that to be like this. So I think you definitely need to check some things out, and all the stuff folks have saying about genitals becoming a little shorter. I've experienced all of that, so I definitely think that you need to be maybe a little bit more structured and disciplined in your approach.
Okay.
I had a guy from a group perfectly healthy before surgery, perfectly healthy after surgery, except ED, and he is bedridden. He has shot to hell his relationship with those around him. He has shot to hell his ability to work and wanted to end his life. Referred him to the Men Speaking Freely group, but he did not show up last week to that. But this is real, and we can't predict how a person will respond. But again, the likelihood of these kind of side effects lasting for your entire life is going to be less with radiation. But you want to go to a radiation therapy that has great equipment and focuses on prostate. I keep on talking about the MRI linear accelerator, but not all programs are going to be focused on prostate. Some are really big on using that technology for brain cancer, breast cancer, or pancreatic cancer, and they don't have the experience. So you want to make sure that you're going to a place that's experienced. Most cases in the country with MRI linear accelerator are at Henry Hudson Hospital in Detroit. At MSK, you have Dr. Nagar, who's head of their urologic radiation oncologist. Dr. Steinberg at Jefferson in Philly, and Dr. Kishon at UCLA. They have a unit at MD Anderson, but I don't know who focuses in that technology.
Well, let me interrupt you a second. Before we get into the weeds of what type of radiation, and it's all good advice, and we can talk about what type of radiation. I first of all, if it were me, I really would want to tie down my diagnosis first. I think it's so important, and so I think to me that's the first place you got to go, Tom. And maybe you are a 4+3, and maybe it is, but you got to get those slides sent out to Mingzhu. He'll talk to you afterwards. Get those slides sent out to Mingzhu and confirm that it's a 4+3. Who read those slides originally?
I haven't on my login. Hold on a sec. Doctor, it's through Northwestern Memorial Hospital here.
Okay. So it was done through Northwestern. I don't know. Jim Schrate probably has a better feel for that than I do. But as good as they are, I memean, I had doctors at UCSF telling me to send out my slides for a second opinion independently. And it's the first thing we tell everybody in AS here, high risk, get a second opinion on those slides. Don't make a decision based on a single opinion of the slides. Jim Schrate.
I think Northwestern is a center of excellence. I think they do a pretty good job of reading the slides. But if you're considering getting treated there, there's a real value in my mind to having a reading somewhere else, and really a reading by an expert like Ming Zhao, I think is extremely important. But I think it makes kind of intuitive sense to me to get it out of the place where you might be treated. It's just, I don't know whether it's a real thing or it's just something that's in my head. But those slides really underlie everything that you're going to do and the treatment and everything that's going to happen to you for the rest of your life. So get them reread and make your decision afterwards.
Okay. Any other comments for Tom?
For whatever it's worth, it's David Muslin. The pathologist was Dr. Isaila, Isaila, first name Bogdan.
Mm-hmm. I mean, the thing is, look, I was at a center of excellence too. And as Jim says, it's really, first of all, it's good to get an opinion from outside of the hospital that's going to treat you. But secondly, as good as these guys are, they don't have the eye of either Mingzhu or the people at the Johns Hopkins lab who have been trained by Epstein. And it's all about how good their eye is. I'm not saying that the institution is not reputable. It is. They just don't see and they don't read the slides the same way. And today, Epstein is not really working. Boswick is still around, but we don't hear about him much because he had to disappear and now he's coming back. Don't know what it is with these GU pathologists, but they all seem to get nailed and then have to return. So the only two alternatives in our view throughout the whole of the country are either Dr. Zhu, who's now at Mount Sinai, and was previously at Tufts, and before that was trained by Dr. Epstein, or the Johns Hopkins Epstein lab, where everybody comes from Dr. Epstein's tutelage.
The other thing I think is really important is timing. We're coming up to a real great time of the year. Normally, it can take 2 to 3 weeks to get your result. But if you throw Thanksgiving, Christmas, and other holidays in, it may very well delay getting the response that you want. And then getting the appointment with the physician to review those findings can take some time. So this is not something I would put off. I would certainly agree with Rick on this. I think I've talked to some people that have taken over 9 months to get in and talk with a radiation oncologist. So I don't think it would hurt to work parallel with the holiday season to line things up, but give yourself a few weeks to get the results back. Um, because it does make a difference. What kind of treatment are you going? What area are you going to treat? Do you need ADT, and if so, for how long? That's all determined by getting a definitive reading on the pathology. Govinda, you have your hand up.
Yeah, only 2 points I like to make. One is, even if you are taking a second reading in a center of excellence, it depends on who there is making the reading. Just saying that it's a center of excellence may not be sufficient. You have to know who is going to read that, as Rick said. That is very important. And secondly, even if you take a second reading, you should also take different opinions before you decide on the treatment. I took, in fact, 5 different opinions before I decided to go with SBR.
But
And
he's done that, Govinda. He's already got,
yeah,
he knows that. He's done 3 or 4 opinions already. The problem is we don't know if he's got the best information to take to those opinions.
What I mean is, after getting the second opinion, if it is different, we should take more opinions before deciding on because the opinions will vary with the reading. The reading is different from what he has. He has to take different opinions after that.
Right.
And I think those opinions are primarily from urologists, and I think that provides somewhat limited. I mean, based on what you've heard, the fact that they're telling you that you're young, do surgery without discussing the pros and cons and putting it in balance.
Yeah, but you know, Tom said he got an opinion at Stanford. Tom, I'm not sure why Stanford or who recommended you. Stanford isn't particularly outstanding or renowned for its prostate cancer treatment. I mean, we could recommend radiation oncologists for you to see. But I think
one. Go on.
Yeah, I mean, I don't know who you saw it, but we got plenty of good radoncs that you can go to, and you can get. But I don't think you're ready for it. I just want to say one other thing to balance what was said before. And there's a bunch of guys on here who did surgery, and there's a bunch of guys on here who did surgery and have treatment regret. I'm not sure, and if there is anybody who did surgery and doesn't have treatment regret on the call tonight, please, I'd ask you to stand up. I wanted to do surgery. I was 56 when I was diagnosed. The only reason I didn't do surgery was that there was a 70% chance I was going to need radiation and hormone therapy anyway. So it just wasn't on for me to do it. And
right.
If you are in a situation where you might need radiation and hormone therapy anyway, then the value in doing the surgery is marginal, maybe 3%, 4%. It's small. Then you have to decide if you want to put yourself in that situation for the 3 or 4%.
Okay, I think we've covered this. Let's move on. Jose, you wanted some time this evening.
You know what? I'm okay. Let other people. It's totally fine. Nothing concerning, and other people have updates. So let them speak.
Yes.
It's okay.
Okay, I'm going to use moderator's privilege, and just note that stress can change your hairstyle here. And in the past week, the stress of what was happening throughout the country and stress in general of babysitting, I've lost this. So hopefully it will come back over time. Rick passed a picture along. He's had stress in his life too, but it seems like all that stress is resolved and he has a full head of hair today for us. Stewart, you're up.
Real quick, as of this morning, I finished my second MRI Linac treatment at MSK and have completed my treatment. So I'm happy to have that behind me. I do have a question, and I was treated by Dr. Nagar, and spoke with him as recently as Friday for a check-in, and said everything was totally standard in terms of the treatment, and to talk again in 3 months. My question is for people who've had SBRT, what, if any, were the short-term side effects after the treatment was done? How quickly did they show up, and what happened?
Who would like to share their SBRT experience? Govinda.
Yeah, I can share my experience, but it is a little outdated because it was done about 8 years back, and today the machines are far better and the margins are far less, so it will be much better than what I had. My experience was that after the treatment for about 2 weeks, I had side effects like um, intermittent going to the washroom, but I never used a catheter or anything like that. And there was erectile dysfunction for some time, but over a period of time, maybe 9 to 1 year or 9 months to 1 year, it has come back. I would say 70% of what it was before the treatment. And twice after about 1.5 years after the treatment, I had some pain and bleeding, which was treated by an antibiotic. It went off quite fast within a week. Apart from that, there are no really lasting side effects as on date after about 8 years. And I think the situation today will be far better because treatments are much superior today. That is my take.
Thank you, Govinda. Jim Stewart. We'll get you next, Richard.
I'm sorry. I wasn't able to raise my hand, and I'm sorry, but I wanted to go back to talk about the surgery because I'm one of the people that Rick was talking about who had surgery and had very different results. And I don't know if I'm just an outlier or what, but I had to have a prostatectomy because I've got the BRCA2 variant, and that was the recommended course of treatment. But I'm 6 months done. I have really from probably a month after the surgery had very minimal incontinence. I'm down to using a small pad maybe for 4 or 5 hours a day. And I've had none of the other side effects, no ED issues, everything was fine. I will agree that having the catheter was probably the least fun thing I've ever done in my life. That wasn't good, but I didn't experience a lot of the problems that a lot of people do, and I just wanted to put that out there as and even though I may be an outlier, surgery I think should not be totally ruled out because of the possibility for side effects. And like I said, I'm sorry to go back up. I couldn't get my hand raised in time, so I apologize to everybody for that. But I did want to make that comment.
No problem. Let's see here. And I'll mention that my situation, I had no immediate side effects, but I'm about 4 years out now. So somewhere about a year ago, I noticed some urgency and frequency similar to before this whole thing got started and got me to the doc in the first place. I ended up with this cystoscopy and had a slight amount of blood in there. And was placed on Trental and vitamin E for 2 weeks, and it cleared it up. I had one episode of incontinence during that time after a long car trip. But other than that, I'm pretty much back to where I was before this whole prostate cancer journey started. Let's see here. Tim in Tampa.
Hold on for a second, Mark. Stewart, what kind of effects are you having?
I had a little bit last week with frequency and urgency, a little bit of burning, had sort of cleared up. And so I sort of expect probably the same this week. Doctor said, you know, he didn't expect, if it happened, he didn't expect it to last more than a week or two. That's really the extent of what I had so far, and that's really the extent of what he's expecting based on the other folks in the trial that have come before me that have all been getting the same thing. Just as we got it's reduced down to 2 treatments, and we got 80%. The one comment I would have for anybody who is planning to have SBRT is take very seriously the prep instructions that you get, because that can make a big difference in terms of how pleasant or unpleasant the build up to the treatment is.
Did they put you on any medicines for the bladder?
Well, I was put on PROSTOX, not PROSTOX. I was put on Flomax after the IRE, and so I've been on Flomax for 7 weeks, and they want me to continue on it for at least 3 months.
So at this point, Aleve might help some, and you might try that for a week. 1 Aleve twice a day, maybe 2 Aleve the first dose, but after that, 1 twice a day. And by 4 or 5 days, if you've not seen any improvement, stop it. But I wouldn't take it for more than 2 weeks, and not on an empty stomach. And that might help with some of those symptoms of frequency and urgency if it persists. Any other comments? Let's see.
Yes, I do have something to say.
Okay.
We don't usually give medical advice, but there are certain people and there are certain exceptions in here who are allowed to do that, like Dr. Mark and Dr. John and maybe others. So I'm just saying.
So I'm not telling you to take it. I'm sorry.
No, you can do
take
it.
Call
You're
your doctor and get on the phone. Usually about 11 o'clock at night, if you page him, will be the best, and that will make you friends and really appreciate it. By Dr. Nagar, don't tell him that I told you to call at 11 o'clock at night. See how he responds. Let's see here. Tim, did you have another comment?
Oh, I was just responding to Stewart's question.
Go ahead, Richard. And Richard and
yes, after my SBRT, things were fine the first week, but then my frequency of urination at night returned. I was going 4 times during I had fatigue the first 2 weeks, but that primarily due to I had SBRT and COVID at the same time, but that's since passed. Let's see, 2 weeks afterwards, urgency increased. Discomfort during urination certainly has increased. Now that is not as frequent as it once was, but there are periods where the daily urination and the urgency are really high, and the discomfort is certainly there, but I just kind of live with it. That's about it for right now. I mean, fatigue has passed, and I guess I'm just living with the urgency, waking up at night, because it was all pre-treatment type of frequency as it is now. So, but I've just figured I'm just going to learn to live with it.
Okay. Tim, you're up.
I wanted to respond to Stewart, but he wanted input for SBRT patients. I concluded my SBRT 5 sessions at Tampa Moffitt Cancer Center on October 30th. And it's been mostly uneventful. I was taking Flomax until the 30th, just to help on the stream, urine stream. And I stopped that, and I'm on Cialis, 5 milligrams a day to help with that. And maybe a little bit of scratchy urine, slight burning, but nothing concerning so far. Again, I had 5 sessions.
Cialis is
Tim, I understand that the people in Tampa are going to be reporting the association between Meridian SBRT and hurricanes. So hopefully that won't happen in any of the other cities. We'll see if it's an ongoing problem with the ViewRay machines, and we'll let people know.
is the Cialis is that's for, this is my ignorance talking. The Cialis is for helping your urine flow.
Yes.
Interesting. Is that a low dose that you were saying?
5 milligram.
I'm just ignorant. Admittedly, I'm not that familiar, other than you see the commercials on TV.
Nick, it's used to dilate the blood vessels and maintain penile blood flow at an optimal level. So at least the story we get from the rat oncs is that it helps protect erections by maintaining blood flow. So normally it's 5 milligrams of Cialis for a day while you're undergoing treatment. I'm not sure how long that continues, unless it's something that you need for sexual functions.
Thank you, Tim. Who was your doctor there at Moffitt, Tim?
Dr. Johnstone.
I wouldn't know him, although I was there about a month ago. It was to see Dr. LSU.
As far as I know, Dr. Johnstone is the one who's focusing more on Meridian prostate. I don't know if you got any other feelings when you were there, Tim.
I think you're right.
He has the most experience. Tug, would you like to go ahead?
I was just going to ask the group with the radiation treatment, if you're experiencing mild symptoms of burning and urine frequency or urination frequency, does that mean, is that like a precursor to getting strictures from the urethra, or just that's a common side effect from radiation?
Well, strictures would be very rare from radiation therapy. And as far as the strictures, that's most often seen after surgery because you have the anastomosis. The section of the urethra is cut out and the two ends are sewn back together. And at that suture line, if there's too much tension on the suture line, you can get stricture. You can get some narrowing at the site, particularly if there's a lot of inflammation in the prostate from that, but that isn't as common.
Oh, I see. So yeah, I just thought maybe it was a side effect from radiation.
The frequency the frequency and urgency are not uncommon, and the smaller the margins, the less likely that is. But again, most people by 3 months, those symptoms, the short-term symptoms are relieved and don't seem to be a problem. Eric, you're up.
Just a quick question of like a clarification. Is SBRT and Meridian the same thing or a variation?
No. Meridian is the machine. Meridian and Electa Unity machines use the MRI to aim the beam. As such, they can cut down for a number of, as Rick says, a number of in the weeds things that we don't need to get into. Those machines allow you to cut the margins down. SBRT is a reduction in the number of sessions. because you're immobilizing the pelvis in a sling. It's kind of like when you get a cast. This is half a cast that you're lying in, and it prevents movement and allows them to have more precise aim of where the beam is going. So you're getting a high dose. Instead of 2 to 3 gray a day, you may be getting 7 or 8 gray daily. So it's a higher dose per day. Overall, the dose is going to be reduced. So with SBRT, your total dose will be about 40 gray, where normally it may be 60 gray or above, but the tissue effect is going to be the same on both those doses. So they are different. One is how you give the dose, how many doses you're giving it at a higher rate. The other is how actually you're deciding, how the machine is deciding where to send the beam.
Cool. Thank you.
Okay, great. David Keller, you're up.
Okay. Thank you, gentlemen. I can get right to my question. I can go into my background, but it really is, I'm talking about urinary urgency. And has anyone in this group had luck with the Kegel exercises? And if so, what did you do? And has anybody examined that device that's advertised a lot on, I guess through my Google News feed now? That's that little pad that has an app that gives you Kegel exercise feedback. So I thought I would just jump right into my question rather than go into my background.
Is it incontinence as well as urgency, or just urgency?
Sometimes, rare. I'm breaking doors down to get to the toilet sometimes, but you know what I'm talking about. It's far more frequent now than it used to be. So have a little level of stress around that whole issue right now, and I think I should probably get serious about Kegel exercises because I haven't done it, but I'm willing to do the work, God willing. If one or two of you say it's been beneficial.
How far out are you?
How old am I?
How far out from radiation?
I'm not out from radiation. I've had doctors want to do a prostatectomy and radiation, but I've held them back because I'm a 3+4 with a low percentage 4. PIRADS 5, large 86 cc prostate, bladder, prostate.
Why are they doing either? Why are you not a candidate? How many cores did you have, and how many were involved?
Because I showed them the studies that say if you're a 3+4 with low percentage 4, you don't need radiation or a prostatectomy.
Right. So why are they suggesting that to you?
They're not. Oh, I'm sorry, because they're ignorant.
It might be. Have you done a Decipher test, and have you had the slides reviewed by Dr. Ming Zhao or Hopkins to make sure that it really is the 5% 4?
Good question. This was my second round of biopsy. The first one was a 3+4. Then on second, it was 3+3 when Cleveland did the second opinion following a local community hospital review. The second one was done by Brigham Young, and I got a 3+4. So I thought, okay, it's a low percentage 4. I wasn't what's the word I'm looking for? Wasn't in a rush to get a second opinion. I understand that it would be a good thing to do. I just wasn't in a rush because I was satisfied that the 3+4 low percentage 4 by an institute that's fairly highly regarded. I was just going to live with that, but I will do a second opinion after this meeting. That wouldn't hurt. I don't know the contact information for this Ming Hu. I used to know the contact information for Epstein, but
yeah, it's MINGZHOU at Mount Sinai in New York, and you can Google it and it comes up fairly easy. I think that's an important part of making your decision, because up to 30% of people who do this may find different readings And I think in your case, that might be important. I'd also consider, you're in Florida, so you're okay. I'd consider looking at the Artera AI. That was newly approved for determination on how likely, if you do active surveillance, it's going to progress and whether you ought to consider treatment. That's Artera, Artera AI.
Yeah.
Not available in California and New York, but that may be a helpful tool to give you reassurance um, as to the risk of not doing treatment. My answer would be that I haven't seen in the patients that I had, albeit my patients didn't have prostates, they had uteruses and such. When these women had urinary frequency and urgency, the Kegels really didn't help. It helped with stress incontinence, but not with the urgency and frequency, and that seemed to do better with medication. Has anybody else had experience? Stewart, you have your hand up. Have you had experience or thoughts on it?
I just wanted to go back to the Decipher. David, I also 3+4, relatively low percentage, and I had a Decipher which came in on medium to high, and based on the Decipher, most of the doctors who I talked to all were not really in favor of surveillance because they believed that the likelihood of having to move on to treatment was going to be high. So if you haven't had a Decipher, I would really recommend getting that to help your decision.
I did the Decipher, I did the Oncotype, and I did the Solaris. Different result with each one. Decipher was, go ahead. Oh, okay. My research on Decipher is that it tends to go on the high side. The Oncotype, I think, was normal, and then Polaris was low. So I had 3 different results from each one of those.
Well, again, I think the finding out on the pathology and getting that reading would be helpful. But I'm not aware that the Kegels would necessarily be a benefit for urgency and frequency.
I'm surprised to hear that.
Let's go on, Richard.
Yes, hi, thanks. I just wanted to report out the last time I was talking about my concern after following SBRT, that I had a 3-month follow-up with the PSA, and it came back 5.6, and I thought that was abnormally high. But when I met with a doctor after that, the oncologist, he thought that, well, since my PSA of 11.7 before treatment was 11.7, it has dropped in half, and that I really shouldn't worry, and I would take another PSA in 3 months. Now, the reason I'm reporting out on this is that being a part of these groups, I had thought that following SBRT that I should have expected something like a 0.5. So I'm just simply reporting this that in my case, he got a 5.7, and it's not a concern to the oncologist. And he said, we'll have to look at this again in 3 months, but he said it's going in the right direction. So thank goodness he reported on that. So my anxiety has diminished quite a bit.
That's great. Thanks for sharing that. Nick, you're up.
Okay, thank you. I'm just got a short report, which is that I'd gone to New York City on the week of, I guess I was there on October 30th, 31st, and November 1st. And I went there to Weill Cornell with Dr. McClure and and followed up with a meeting with Dr. Nagar on Friday the 1st and had a biopsy on the 1st. Thankfully for me, the testing, the PSMA PET scan and the biopsy all showed that I was still within the criteria for the RTIRE clinical trial, and I am now scheduled for my irreversible electroporation procedure December 9th.
Fantastic. Stewart, do you have any guidance or anything to add for him?
I should also say that Stewart has been beautiful to me and has been talked to me on several occasions already, and I'm shutting up. Stewart can say whatever he'd like to say.
No, I was just going to say, we've been talking for the last month, so Nick's getting the benefit of all of my experience.
Absolutely am. Thank you for that.
That sounds super.
Also, for the rest of the group, I'll say quickly, I am somewhat similar to Stewart in terms of I am a Gleason score of 3+4. I got diagnosed in late July, early August with the 3+4. I have gone to several different places, including Moffitt. I've been looking at the focal therapies, but I've been lucky enough to get into this RTIRE trial, which is a combination of the focal therapy using irreversible electroporation with a follow-up of 2, what Dr. Nagar called lower dose. Lower dose meaning there were only 2 doses. As Stewart said, he got 2 doses instead of the 5 or 6. And it was about 80, the dose is approximately 80%. Dr. Nagar did say to me when I met with him that it still has therapeutic value, and the way they look at it is, since the radiation is a follow-up to the focal therapy, that's actually the normal follow-up dose. Perhaps Mark or somebody else may want to correct me or elaborate on what I just said.
The range of doses that I've seen for SBRT is 36 to 40. Occasionally, in the safe area, they'll boost to 42 gray, but doing 36 in 2 sessions versus 36 in 5 may be more biologically active. I mean, it's a sufficient dose that if there is microscopic disease in other areas or areas of concern, that's going to address it. So it's not a low dose. It's not just waving a wand over it and see maybe we'll hit something. I mean, it is a therapeutic dose that should take care of things.
So before anyone else leaves, I just want to, because I'm listening to this conversation and I'm realizing how valuable it was for Nick when he made these decisions to be able to communicate with Stewart.
Super valuable. Also super valuable. Excuse me, go ahead, sir.
I don't think, what is it they say in the MasterCard ad? What is it they say in the MasterCard ad? You know,
priceless.
Yeah, you couldn't pay for that.
Well,
so,
you couldn't pay for that. Rick, you can. You can go to AnCan.org and make a donation so that we can continue to pay for our assistants and our.
Well, I wasn't exactly going there because I save all my donation stuff until December, because we don't like to ask for money until December because you get so fed up of hearing it from the other organizations. But here's what I am going to ask you all to do if you haven't done it yet. So I won't shame you by asking who hasn't done it yet, but we send out a survey on Friday morning. And oh yes, and I'm glad somebody just put their camera on, because a huge shout out to Colonel Boykin, because he helped us, and a huge shout out to Dr. John, who helped design the survey. And we have not gotten the response I was hoping for, and we will be chasing everybody up. But for 5 minutes of your time, please respond to the survey. It helps you, it helps us, and you can't get this anywhere else. And we want to hear from you. If you're not happy with what we're doing, tell us. We'll change it. But don't let that survey request languish in your inbox and just move over it. Because honestly, some people, like Dr. John, finished it in 6 minutes. Some people took a lot longer, but most people are getting it done in 9 minutes or so, and it's easy. And we really want you, please, to respond to the survey, and we'll keep pushing this probably right the way through the month of November. So thank you all of you for responding to the survey, and we won't be asking you for money for another 3 weeks yet.
Okay. Let's move on to John S. You had wanted to make a comment.
Yeah, good afternoon, guys. Good evening. Stewart, I missed you at MSK today. I got my tattoo, so anyway, I finally made the decision. I did speak to Dr. Nagar about the spacer. He did call me up. Even I had an in-office meeting. He did call me up 2 weeks ago. He was kind enough. He told me, look, as I explained to you in the office, you don't need it. So I opted out of that. That's good. Today, what else? The other thing I asked him about, I have 2 cores, 3+4, and very little, 7.8 millimeters, but 20% 4, and 1.8 millimeter, 35% 4. Even though they're small, I guess it puts me out of the active surveillance. So I think there's other background stuff going on. He says, look, I would love to put you on active surveillance, but you're not a candidate. So that was it for that. So anyway, the other concern, I don't know if a concern, he did come out today. I asked him and I met with him. Now he's given me 3 treatments Thanksgiving week, 25, 26, 27, one after the other. So that had me a little concerned, but he's not worried about it. And then I come back 6 days later for the other 2, December 3rd and 4th. And I don't know what else to say. That's about it. And the other thing you guys haven't mentioned is the pathology at MSK. I'm sure they're top notch there too, correct? And I'll leave it at that for now.
Well, the answer is they're top notch, but they're not as good as you, and they're not as good as Hopkins. They're all top. Northwestern is very good. UCSF is very good. MD Anderson is very good. But for prostate cancer, if you want a second opinion, you've got to get it from either Zhu or Johns Hopkins. Okay, don't be asking us, well, is it as good? No, we can tell you ahead of time, it's not as good. It might be fine, it might work. It's not as good as getting an opinion on your slides from Hopkins or from Dr. Zhu.
As was mentioned earlier, it's not just them looking at the slides and coming up with an experienced diagnosis. It's getting on the phone and talking with you and giving you the information to help you make decisions about what that path report means. We all get the paper with all those numbers on them, but what does it mean and how do we interpret it? They're going to do a better job communicating that to us than the average urologist might. And that's another part of the consult is making sure you get what you need out of their intervention and review. Jim Schrate, you're up.
I didn't have my hand up.
Oh, I thought you said in the beginning that you needed time.
No.
Okay, that's great.
Thanks.
And I think, Tim, we got to you. and John is gone, or Joe is gone, I think. I don't see him any longer. There's a caller on the phone. Do you need time this evening? Caller on the phone. Do you need time this evening?
Is that Henry? It's probably Henry. Who's on the phone there? My bet is it's Henry.
Well, that's okay if they're not speaking up. Does anybody have any other comments, concerns, or issues they would like to bring up to the group tonight?
Oh.
Well, that's good. Thank you so much. Let's see. It looks like a lot of us must be sharing that stress that we may be feeling, and hopefully it doesn't spread. I don't think you can catch that through the internet, so I think we'll be okay. And I appreciate that. If nothing else, we'll call it a night here and see you guys in 2 weeks.
Dr. Mark, yes, I have got something to tell you. I just want you to know that there was a piece on NPR this morning about emotional llamas, therapy llamas at the Portland airport.
You know, someone came up to me today. I was at I was at the airport with Andrew, and he's been getting film crews following us at various places. Now, I did not make it. This is a funny story I should share.
You may have to explain why this comes about. Not everybody may know about you and Andrew.
Okay, hold on. No, Andrew isn't here, but this is a picture of the emotional support dog. And he wasn't invited, but I got a call from Dr. Kishon at UCLA asking if I would like to represent them at an Intercept Cancer event with the Chargers. And I said, sure. I wasn't aware, actually, that the Chargers had moved from San Diego. That was the last I knew, that the San Diego Chargers. I didn't announce that when I got there, but they have a beautiful, beautiful new facility right near the airport. The building has this big lightning bolt, which is the symbol for the Chargers now, their logo. And in the parking lot, because of the Chargers, they had EV chargers for just about every space in the parking lot. The only thing was none of the chargers worked. They said it was because of the new building. They were relatively recently moved into this new training facility. I'm not sure it's that, or maybe the manager that's involved. And they had us go around, and they had a TV crew interview. I thought it was going to be a bunch of people. 2 of the people looked like they were really having a tough time with their cancer struggle. One was going on, but still looked healthy. And then there I was 4 years out, and felt pretty good about this. So they took pictures. They had a TV news crew interview me, and the TV guy says, "Okay, do you have any last words for us?" And I said, "Wait a minute, my PSA is undetectable. I'm not at the last words phase. I wouldn't mind a last supper because the steaks they were eating inside the dining room looked really damn good." So 2 days later, we went back and went to the game. And what I didn't realize, that all these pictures would show up on the Jumbotron in the stadium. So, and they kept on doing it, Intercept Cancer. And there it's just, I'm in the conference room, sitting in the quarterback's chair, and I'm the only one in that facility, and they're showing that picture on the Jumbotron. It was a bit bizarre. It was bizarre, but fun. But no llamas. Someone told me about that today, that they had seen the llamas in Portland. But it's fun. We enjoy doing it. So anything else for this evening?
Nope.
Just real quick, happy Veterans Day, and to the veterans among us, thank you.
Thank you, Jim. Thank you for raising that. Thank you, thank you. Colonel Boykin, did you get your free meals? Everywhere you could have had free breakfast, lunch, and dinner. And you, Causley, did you get your free meals today?
I stayed home today and resisted the temptation because I didn't want to put on any more pounds.
Okay.
I will remember here to shut us all up, so you guys don't have to listen to 3 hours of dead air afterwards to get to the right spot. So thanks again to everybody. See you in 2 weeks.
Thanks.
Good night.
Good night.
Good night.
Thanks.
Thank you.